so there's a lot of discussion about what else can we add to locally advanced therapy to make it better or worse. You know, in the MAGIC studies, you use anthracyclines. There's been some discussion now in the metastatic setting. Do we still need to use anthracyclines? Do we not? And I want to take a poll. I'm going to start with Ian, but I'm going to go around the table, and I want you to say yes or no, both for locally advanced and metastatic.
So if we talk about locally advanced disease where we're given perioperative chemotherapy, because we're still following the paradigm of MAGIC, so therefore we will routinely consider giving triplets, epirubicin, cisplatin, often in conjunction with capecitabine. When we move to metastatic disease, again, a triplet is really for fit patients, okay? So I think the number one thing to decide is what is the performance status and what are the comorbidities. And certainly if they have comorbidity, which is a contraindication to anthracycline, then we would not give it. Now, for a very fit patient, then the next thing is, do you have to give triplets? I now, my own opinion, okay, is that I don't have to. Okay, so certainly, and also I do now believe that in clinical trials to add an extra drug onto a triplet is getting very difficult because we are already really reaching the maximum tolerated dose already with the free drugs. You add in an extra agent, a novel agent, that really is that's usually take the patient over the limit. So I think a lot of the times when we're looking at new drugs, novel drug we will try to bring in, I probably would favor more a two-drug platform and then to add in your new agent. You know, so certainly I think is one of those that epirubicin is an option, but I don't think it's an essential option.
Okay, poll number 2.
It's very refreshing to hear that from Earl Morrison.
We have insights.
You're becoming a U.S. oncologist.
David Cunningham's going to be waiting for you at the door.
Well, it's funny because David Cunningham at ASCO, after presenting EO5 data, clearly stated that the role of epirubicin is diminishing in both treatment of metastatic and even locally advanced disease. I will start with the easier answer. For metastatic, there's really no role for epirubicin. You know, even the NCCN guidelines have recently changed, and in fact, members of the gastric, you know, sort of thought leaders, so Jafar Jani, myself, and Dan Catenacci, and several others have actually recently published a statement piece in the JCO trying to, you know, put an end to routine use of epirubicin in metastatic setting. Ian's point is excellent. It's hard regimen to build on with biologic therapy, and also, you know, limits your ability to get second and third line therapy in. What I tell my metastatic patients is that this is, it's a marathon. This is not a sprint. We have to strategize and plan ahead for second, third, and so on therapy. And you know, and I think to double it in a first line therapy allows you to do that. With locally advanced disease, it's a little, the data is softer, I would say, but more and more, particularly for G-junction tumors, you know, epirubicin has really lost track with the EO5 data. But I would probably not use it. I hardly ever use it in local advanced
And
disease.
certainly not in conjunction with radiation.
Certainly not. But even for gastric, you know, distal gastric cancer, majority of these patients are older, nutritionally compromised, and you just can't get epirubicin into.
Third. So I echo what has been said already. I think that it's been long recognized that epirubicin adds little. For me, I actually maybe was a longer holdout of using epirubicin because the MAGIC data in a curative setting was actually the best data, 500 patient study, and improved survival, and it actually was powered for survival and did its job. So it was hard for me to sort of take the step that maybe epirubicin isn't used, although I have a very low threshold to not use it if someone has toxicity or if someone doesn't look like they can tolerate it, then I drop that one first. With the OEO5 data coming out, which was not in the same setting as esophageal cancer, not gastric cancer, but it does sort of question the role of epirubicin in that disease. And so I think, I'm using it less and less in the perioperative setting, although I still do use it. In the metastatic setting, I think that, and we'll talk about this, and you've alluded to it, that there are actually increasing the number, options for patients. I mean, it's incredible. When I first started practicing, which wasn't that long ago, patients, sometimes didn't get first-line therapy. They would come to me untreated, saying that my doctor didn't think that there was more treatment. And now it's second and third line, and some people are getting longer than that. And so I think really the era is changing, and it's really exciting. So I find that there are other drugs, and so I really don't use epirubicin in the metastatic setting.